Hello, everyone. Hello, Professor Rainier. Hello, fellow classmates. My name is Kea Mariking Perido, and this is the topic that I have chosen to discuss as a lecture in a computer based strategy. So, this lecture will be the final requirement compliance for the subject instructional leadership and management. As for the brief explanation of the situation behind this lecture, I am the clinical instructor for the level 4 student nurses in Wesleyan State University, Philippines. This lecture was given in preparation for the level 4 students in their clinical exposures to the post anesthesia care unit. Hello, level 4 students. How are you? So I know that everyone is happy and relaxed after the summer vacation. So I am the first lecturer to give you this topic about a post anesthetic complication. So I have prepared this topic in preparation for your uh, clinical exposures to the post operative departments. And I know that most of you is unaware of this complication yet because this seldom happens. But I want you all to be ready and significantly aware as well as well equipped to handle this complication if ever this occurs during your clinical exposure. So, let me briefly introduce to you what malignant hyperthermia is. So, malignant hyperthermia is an uncommon complication during or after the administration of inhaled anesthetics or the muscle relaxant succinylcholine. This complication is actually life threatening or deadly in nature. So that's why we should be very cautious in determining the signs and symptoms, as well as to take into heart how we can manage this complication. So let's start off with our learning objectives. By the end of this presentation, I want you all to be able to analyze malignant hyperthermia, the causes, etiology, epidemiology, explain the pathophysiology, nursing and medical diagnosis, as well as the management. Then, we should be able to correlate nursing management with the complications identified with malignant hyperthermia, or MH. We should also develop effective skills, as what I have said earlier, in symptom recognition and differential diagnosis. Next is to apply the knowledge acquired in the nursing management of malignant hyperthermia. And last, I want you all to create a smart care plan, specific, measurable, attainable, realistic, and time bounded for patients with malignant hyperthermia. So let's start off with defining malignant hyperthermia. So this condition is life-threatening. It is genetic in nature, autosomal dominant in nature, and it is characterized by a hypermetabolic state and rigidity of the skeletal muscles. So there are two most common causes of this condition. The first are the inhaled general anesthetics, which are the halothane, sevoflurane, desflurane, among others. The second one is the muscle relaxant, succinylcholine. So these two medications are given intraoperatively while the patient is actually uh, being prepared for or while the patient is being operated. So MH is actually idiopathic in nature. So what does idiopathic mean? Anybody knows what this term is about? Yes? Raise your hand, please. Okay. Right. That is correct. Idiopathic means unknown. So we don't know the specific cause of this condition. And this condition actually occurs in children, the prevalence is 1 in 30,000 and 1 in 100,000 among adults. It is mostly prevalent among males. However, the mortality rate is higher among females. Next, it is an autosomal dominant disorder. So, what does it mean? It means that it only takes one gene among any of the parents that this gene will be passed on to the child for him or for her to exhibit the condition or the signs and symptoms. And disorders associated with the susceptibility of having MH involves a central core disease, usually diseases which involves the skeletal muscles, like um, the Denborough syndrome, a rare myotonic condition, and myopathies characterized by hypothermia and weakness of the proximal muscles. In order for us to develop a care plan tailored fit to the needs of the patients with malignant hyperthermia, it is a must for us to determine the processes behind the medical condition or the pathophysiology which had led to its occurrence. So, there are researchers which actually testified that patients with MH susceptibility have this defective gene. So, when these patients are exposed to the triggering agents such as the inhaled anesthetics and the muscle relaxant succinylcholine, it triggers the influx of calcium. And as we all know, the electrolyte calcium is responsible for muscle contraction. However, in malignant hyperthermia, the influx of this calcium causes a sustained muscle contraction. So, in order to maintain the contraction, the muscle cells then use the anaerobic metabolism pathway. And as we all know, if the body uses anaerobic metabolism, it produces lactic acid or acidosis. The muscle cells then deplete the ATP or the energy source and die. So as these cells degrade, they release the potassium and the myoglobin into the bloodstream. So what happens when potassium is released into the bloodstream? We all know that hyperkalemia can cause cardiac dysrhythmias. And cardiac dysrhythmias are life-threatening. And what happens if myoglobin is released into the bloodstream? So it blocks the renal tubules, which causes kidney failure. It also blocks some cells in the liver, which causes liver failure. And also, the increased oxygen demand of the muscles from the sustained muscle contraction causes the buildup of carbon dioxide. The buildup of carbon dioxide can eventually cause tachycardia. Tachycardia is a compensatory mechanism to blow off the excess carbon dioxide from the body. Furthermore, if there is sustained muscle contraction, it also increases the body temperature. And this increase in body temperature is actually 1 degree Celsius every few minutes and can lead to cardiac or organ dysfunction and eventually death. So, based from the pathophysiology of malignant hyperthermia, we can foresee the possible signs and symptoms associated with this condition. So, the early signs and symptoms include unexplained tachycardia or arrhythmias. The arrhythmias may stem from hyperkalemia, and this might be VTAC or PVCs. Next, because of the accumulation of carbon dioxide in the body, there is hypercarbia. And due to the increased or sustained muscle contraction, there is a depletion of oxygen levels in the body, leading to hypoxemia. There is also masseter muscle rigidity due to the sustained muscle contraction. And as a compensatory mechanism of the body to decrease temperature, the body will produce sweat. And there will be also mottling of skin. And because of the cell degeneration or degradation, there will be acidosis and hyperkalemia. There will also be generalized muscle rigidity. So there are also signs and symptoms associated with the late stage. Coagulopathy or DIC. DIC means disseminated intravascular coagulation. So because of this recurring complications like hyperkalemia, acidosis, hypercarbia. So there is a disruption in the coagulation pathways of the body, leading to DIC. There is coagulation, however, it is mostly on the bleeding side. So uh, the body has a tendency to bleed more because of this irregular coagulation. So that's what DIC is. Then rhabdomyolysis. Rhabdomyolysis means the degradation of the skeletal muscles. Kidney and liver failure because of the accumulation of the myoglobins in the bloodstream. Temperature increase. This temperature increase might or may not occur during the late stage. So it depends, case to case basis. In order for us to diagnose malignant hyperthermia, should be a clinical evaluation to correlate the signs and symptoms with the laboratory tests and also to develop a differential diagnosis. We should also test for the complications. We should also take histories on the susceptibility testing for people at risk. So we need to ask the patient if he or she had complications or adverse reaction when being exposed to triggering agents. We should also ask if there is a relative who had undergone a procedure and has received anesthetics and developed significant reactions to it. Next, caffeine hallucine contracture test or CHCT. This test, a muscle biopsy is taken, and this tissue is exposed to halothane and caffeine. A positive reaction means a positive diagnosis. Next, we should also conduct, if possible, genetic testing. So, genetic testing can reveal mutations in RYR1, STAC3, which are actually some genes located in the DNA. There are 45 mutations that are recognized as diagnostic for malignant hyperthermia. So, as nurses, if you are able to distinguish that the patient had developed a complication to the triggering agents, we should call for help immediately because time is gold in managing this medical condition. So we should also bring the MH cart to the bedside. I will discuss you later what are the components or the contents of this cart. We need to hyperventilate the patient with 100% oxygen at a flow rate of 10 liters per minute because there is a depletion of oxygen supply in the body. Next, we need to assist or to prepare to assist in intubation. And these charcoal filters are usually available in the operating rooms, and this would help to remove the volatile anesthetics from the breathing circuits. We should also insert IV access, cool the patient with normal saline, to decrease the body temperature, and we need to give medications as prescribed. So, the drug of choice for managing this complication or for managing MH is dantrolene. It's also a muscle relaxant. However, it is different from succinylcholine. So, dantrolene is a direct acting muscle relaxant. So, it doesn't trigger the reaction uh, like what succinyl does for patients with MH susceptibility. Actually, even though it is a muscle relaxant, it is a drug of choice to manage malignant hyperthermia. And also, we need to document what we have done to manage the patient. So, without documentation, it means that it isn't done. So, we need also to be careful with that. So, these are the nursing management for patients with MH in the post acute phase. We should monitor for relapses because there is a tendency for relapse in the first 24 hours. And we should remember that these relapses are fatal. Then we should also monitor for changes in the level of consciousness, vital signs, clinical severity of patient's condition. We should also monitor the lab values since the lab values would indicate the complications that the patient might be having. So we should monitor the lactate levels, the electrolytes, ABGs. ABGs will tell you also the hemoglobin level, the oxygen level, the glucose, if it's respiratory or metabolic, acidosis, if it's compensated or not. So ABGs are very relevant. We should also monitor the coagulation studies because of the bleeding tendencies, the kidney function tests, and myoglobinuria. We should also monitor urine output because of the tendency of kidney failures. We should also administer diuretics as prescribed to decrease the potassium level from the blood. And we should also give 8.4 sodium bicarbonate to combat lactic acidosis and administer the drug of choice, dantrolene. So, what are the components of your MH card? So, in any post operative department or any post anesthesia care unit, there is an MH card. So, these are the contents. The 2% lidocaine or amiodarone, this is to manage the cardiac dysrhythmias, 8.4 sodium bicarb, to be given as an IV push to manage lactic acidosis. 10% calcium chloride to manage the cardiac dysrhythmias. 50% dextrose and regular insulin. IV normal saline to flush the medications. And dantrolene. There are two brand names associated with dantrolene. If you're using dantrium, you should have 36 vials. And if you have Ryanodex, you should have 3 vials. So what is the difference between Ryanodex and dantrium? So they are the same. It's only the stock that is available. Since the stock on hand for dantrium is actually lower compared with Ryanodex, but they are the same. So anybody in the class who can explain to me why there is a need to give insulin and 50% dextrose? Is the patient having hyperglycemia? That's why we need to give insulin. Does anybody have any idea? Okay. Yes. Can you tell me? All right. Mm-hmm. 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 All right. So you're correct. The patient is not having hyperglycemia as a complication. So this insulin and 50% dextrose is given to reduce the potassium levels in the blood. So by the concept of cellular ion exchange, when insulin is given in the body, it ferries glucose into the cell, and it also ferries potassium. So, if you're giving insulin in MH, it is to manage hyperkalemia. So for the supplies in the MH cart, there will be 60 ml syringes for Dantrium and 5 ml syringes for Ryanodex. There will be 60 ml catheter tip syringes with irrigation tray to decrease the level of temperature of the patient. There will be ABG kits, syringes, point of care test kits, buckets for ice, disposable cold packs to decrease the temperature. There will be blood collection tubes to check the lactic acid, the coagulation studies, kidney functions, liver function tests. And there are approved core temperature monitoring strategies because the one that we usually use, like the axilla or the oral temperature monitoring, is not as accurate as the ones that we have to monitor the core temperature. We should also have this central venous and arterial catheters that is for invasive blood pressure monitoring. We should have the transducer kits for this arterial and CVP lines and the urine meter. We should be very careful and very cautious in managing and using these medications and supplies in managing this MH. And as for the complications of MH, based on the pathophysiology, we can now foresee or we can now analyze the possible things that could happen if the patient is having MH. So there might be cardiac dysrhythmias, seizures, pulmonary edema, kidney failure, DIC, compartment syndrome, skeletal muscle degeneration, and even brain death. All right, so that ends our lecture. If you have any questions, feel free to raise your hand. Okay. Mm-hmm. Yes. Mm-hmm. So actually, this type of diagnostic test, it depends on the hospital if they are able to do the CHCT, because not all hospitals have this availability of diagnostic testing tools or testing kits. So it depends. So if you don't have this diagnostic test or the gold standard for diagnosing MH, it is relevant that the healthcare provider and nurse should develop a differential diagnosis and diagnose MH based on the clinical signs and symptoms and also based on the history. All right? Okay. Any more questions? Nothing more? All right. So I'll be putting an assignment on the Canvas email. The deadline will be a week from now. And you can also, if ever there are questions that I may not be able to address during this lecture, you can send me an email on the Canvas. All right. Thank you. Have a good day.